Okay. Welcome to the Health Informatics Seminars. I'm David Potenziani and will be hosting today. Please remember that today's seminar is being recorded. Do mute your microphone while we're listening to and viewing the presentation. However, when we come to the Q&A segment, feel free to unmute yourself and pose questions or make comments for the presenter to discuss. We may also have some from the students here in the classroom with me. Alternatively, you may post in the chat where I'm happy to relay your question or comment. So let's begin. Today we will hear from Dr. Mamdi Osakwe, and I turn it over to Professor Damodaran to introduce our speaker.
Thanks. It's a pleasure to introduce Dr. Namdi Oswaki, who was our own NCCU product. He's a postdoctoral research fellow at the moment at Global Research Institute, College of William and Mary. So at GRI, he is working in Global Health Lab, where he is developing a surgical need index that combines human biomonitoring, environmental, economic, and social determinant data using machine learning to quantify pediatric surgical health disparities across the global south. Prior to joining GRI, Namdi received his PhD in bioinformatics from North Carolina State University, where his research focused on developing data-driven environmental health assessment models at varying geographic levels. He also received his BS in biomedical sciences from North Carolina Central University, where his interest in bioinformatics and health disparities research was initially cultivated. By the way, he was one of the few student leaders, the founding team for the Biology Honor Society, Tri Beta Biology Honor Society, where I have the opportunity of working with him. It was a pleasure that he has grown. He brought several new things to the campus in several different programs. We really appreciate his contribution. Outside his research, Namdi actively engaged in science outreach and communication efforts. He has extensive experience mentoring students from undergraduates to graduate levels and also contributed to the development of science and data literacy curriculum. Dr. Namdi, thank you.
Thank you, Dr. Damodaran. My name is Namdi, and today my talk is going to focus on data-driven approaches in assessing cumulative impacts and need in health disparities specifically. So a lot of my work during my doctoral program focused on leveraging machine learning to develop environmental health risk assessment models. And now in my postdoc, I'm leveraging a lot of the technical expertise specifically for global health accessibility as well. So go ahead and begin. So usually when I talk about the work that I do, I like to at least start with the foundation of why we actually do this. And not just on a local level, but also at a global scale as well. So according to the World Health Organization, over 20% of global deaths are caused by environmental health related causes. And if we focus now on more US-centric or the United States specifically, especially with focusing on water quality, over 2% of water systems in the United States are classified under the Safe Drinking Water Act as serious violators and the Clean Water Act as significant non-compliers for underperforming and under-delivering on water quality standards. Now we focus on the effects of potential mediating effects of water quality or other environmental factors on health outcomes. The median blood level for children living in families with incomes below poverty level is higher than for children living in families at or above the poverty level. And so we started to see intersectionality of not just environmental exposures, but also the effects across different demographies and disproportionate effects as well as we move on to cardiovascular and respiratory related issues. So think of asthma disproportionately affects children from lower income families and children from various racial and ethnic groups. And we look just more so back across the nation. 97 million people nationwide lived in counties with pollution levels above the primary national ambient air quality standards. So it's one thing to actually see these statistics and to read them and to be able to point to reports that actually exemplify them. But the reality is that whether we're talking about different policy implementations, regulatory factors, despite the progress over the past few decades in addressing these issues, the reality is that different crises, different communities are affected by exposures to various contaminants, various environmental exposures. Where we're talking about arsenic exposure, uranium, chemicals and toxins found in well water, or even in North Carolina, Cape River Basin region specifically, PFAS chemicals, forever chemicals, and the effects on communities as well. So there's progress that still needs to be made in addressing just the totality of environmental factors and their effects on communities as a whole. So when we talk about the environment, what I'm essentially focused on here is related to where you live, the water you drink, how you live, all these factors, whether you live the proximity to a landfill, to industrial site, climate factors, traffic factors, population factors, health outcomes, social economic factors as well, all these social determinants, all these different determinants as well, and how they affect human health over the course of a lifetime. So think these cumulative impacts. This is known as the exosome. So the impacts of the total environment on a human health outcomes. And my focus is more so how can we leverage data to identify these different drivers affecting human health at the local community level. And the main tool used to really screen a lot of cumulative impacts are known as environmental health screening tools. So I have a working definition of environmental health screening tools, and these tools provide monitoring and risk metrics for environmental and social determinants of health and their impacts on human health outcomes for specific areas of interest or geographies. Again, this can include pollution burdens and exposures, again, climate impacts, population characteristics, different social determinants in that regard, and health outcomes as well. And these in totality affect aspects of environmental health. And these tools help to identify the impacts that all these different multidimensional indicators and stressors have on human health at varying geographies or geospatial levels. So when we talk about environmental health screening tools, I categorize them based on their geographic level of focus. So think of the global scale, multinational scale, down to, we're talking a US-centric, more national scale, even sub-national scale or regional scale. So for more multinational environmental health screening tools, we have the Environmental Performance Index, the Yale's Environmental Performance Index, that focus on comparing nation to nation when it comes to different factors related to environmental quality and impacts, even as well, not just economically, but also health-wise, human health as well as environmental health as well. And we think of the US-centric, more so national environmental health screening tools, such as the Climate and Economic Justice Screening Tool, the CDC's Environmental Justice Index, the EPA's EJ Screen and Enviro Atlas, that focus on comparing on the entire country, different localities, down to the census block level when it comes to aspects of environmental quality as well. And even with think statewide or more regional environmental health screening tools, such as NC EnviroScan, California EnviroScreen, Colorado EnviroScreen. These tools then focus more so on, again, the states or regions of interest and the populations there, and as well as indicators and stresses most prevalent, more affecting those communities. Now, as effective as they are, and especially comparing location to location, as well as, again, a great picture of the cumulative impacts from a number of multidimensional stressors, not without their limitations. One main takeaway is that a lot of these tools essentially monitor have a set monitored indicators that they focus on. So this limits really our understanding of distinct stressors and those that may be disproportionately affecting specific communities. What I mean by that is that you may have a set number of stressors that are compared across the entire nation, but certain pockets, certain states, maybe certain regions within certain geographies are more disproportionately impacted by certain stressors. As I mentioned, for example, let's say in the Cape River Basin region in North Carolina, communities are more disproportionately impacted by PFAS chemicals in their water supply compared to maybe other areas in the United States. But because many of these tools focus on a strict standard monitored indicators to compare one area to the other, those distinct stressors that may be impacting specific communities are not as monitored or tracked. Secondly, there's a limited weighting scheme when it comes to the importance of the effect of one stressor or the effects of a number of stressors on our understanding of characterizing environmental health for a given area or a location or a community. And because of this, the understanding of what's actually driving the most impact towards various health outcomes for a given community is limited in our understanding in that regard. And thirdly, there's inconsistent efforts towards effective community involvement pre, during, and post development of these screening tools. Each of these tools employ their own method of engaging with stakeholders at their varying geographical levels of interest, but it's an inconsistency in actually applying this approach pre, during, and after the fact of the modeling approach as well for developing the screening tools. So with that being said, with these limitations, my focus in my work is to focus at the local level and addressing the local level and developing a framework to help facilitate addressing these gaps, where we focus on data integration, which all these tools essentially do. They focus on integrating multidimensional, even multimodal data, dealing with different environmental stressors, exposures, and social determinants, and their impacts on their given geographies. However, my focus is more so focusing on those that are most relevant to a given community at that varying geographic level. So this is notwithstanding comparing one community to the other, but more so relevant to those needs within a resource-deprived area. And then indicator selection. How do we actually identify those stressors, those determinants that are most important or driving this effect of environmental integrity or environmental health within that community context? And then indicator factor weighting and scoring. How can we actually gauge what's driving the most impact from what we selected from our data integration to indicator selection? And then how do we develop a score, a metric that best quantifies that? And as well as how we actually benchmark those scores as being important based on that level of interest. So overall, the idea is how can we essentially communicate cumulative impacts of environmental health tailored to address community health disparities? Our focus is not necessarily on more of these national-based screening tools or some of these statewide screening tools, but more so at the community level, specific communities, those stressors most impacting those communities that help facilitate factors to help address those specific issues of interest. Yes. So we talk about data integration. More typical or more conventional data integration methods for environmental screening tools, as I mentioned, where you're talking about pollution burdens, exposures, health outcomes, climate impacts, whatever it may be. Again, focus on kind of these three main areas. So, of course, domain expertise, subject matter experts help us facilitate what's actually important related to specific health outcomes of interest, right? And what we monitor, what we collect, and what we use to analyze to develop a screening tool. Also, we also rely on evaluating and reviewing current state of the field regarding indicators of interest, right? What does the literature tell us about what's actually important? What studies show association, even causal inference in the effects towards specific health outcomes of interest? And as well as it's also depending on monitoring and different response data and what's actually available to be analyzed and incorporated within these different tools. So most tools, as I mentioned before, again, focus these main two elements as well. But a bottleneck, of course, is this third element of where the data availability, which is a bottleneck in any type of analysis that you're doing. And we're focusing on this community-focused context. The main takeaway with this framework is that it allows that instead of just relying solely on domain expertise, we also rely on including data that's relevant to the communities of interest that's fed from what's actually found within that community of context. So we're not just focused on what's actually monitored across the entire nation with means of comparison. So if in one community, let's say one state, these specific indicators of interest are covered or actually monitored over time, but another state the data is not as available, then that indicator may not be included in the screening tool. But our focus is focused on what's actually available in that community, what's relevant, what's actually needed, again, and then developing or incorporating those specific metrics in addition to what we know from domain expertise and subject matter experts on what's actually important in regards to affecting or impacting environmental health for a community. Next, stressor variable selection. So the main objective when it comes to actually selecting what's actually important or driving, the approach is more so to leverage supervised machine learning techniques versus supervised machine learning techniques. The idea is to essentially, we want to identify and identify the relationship and the association that these stressors, whether they're environmental exposures, social determinants, and how they associate with one another. And then from that point, the implication is that their association is related to the effects of and different health outcomes versus having a specific health outcome of interest that we're focused on. So we want to know the relationship that all these stressors have with one another in actually driving the change in the community versus necessarily a specific health outcome of interest in relation to a pool of indicators or stresses of interest. And we do this by leveraging dimension reduction analysis as a means of feature selection. So the idea is using dimension reduction analysis, like principal component analysis, for example, is that we're trying to combine all of these stressors of interest, whatever they may be, and then summarize their associations and how and their effects on the variation within a given data set. Each of these data sets would be focused on that given community context. So data that's targeted and focused on that specific community will be used to then identify all the stresses incorporated, how they actually associate one another, and what's actually driving the change, driving variation, variability within that data set for that community. From that point on, for each of these principal components or these axes specifically, we then leverage the contribution that each of these stressor variables specifically are contributing to each component and perform a weighted mean average to identify the cumulative effect of each of these variables on the variation in that data set. So essentially, we're getting a better idea of the contribution that each of these variables are having on the variation across that specific data set. From that point on, we then rank each of these variables' contributions and then select n number of top variables of interest based on their contribution to total variation within that data set. So the idea is that we're selecting those that are most important in driving the change across the entire data set in of itself for that specific community. And then the implications that we're doing to assess how well these specific variables help us in understanding effects of different health outcomes for that community context. Next is score and weight creation. So how do we actually then characterize these impacts? So as I mentioned, we're leveraging dimensional reduction analysis to then identify what's actually driving the change, driving the variability within that data set for a given community. And from that point on, we then leverage those values based on the contribution that each of those variables have, and then we leverage those as weights of importance based on how it's impacting health or health integrity within that community context. So how does that actually compare with the conventional, more typical environmental screening tools, weighting scheme approaches? Well, let's say we have city A and city B. You have a number of different indicators or stressors that we're focused on in city A and city B. A more typical approach would have an unweighted or a same weighting scheme for each of the stresses of interest. Now, this may make sense in comparing one area to the other. You don't want to give more influence to one factor versus another, depending on the different area of interest, or just based on just lack of understanding the effects that they may have on a specific health outcome that you're actually focused on. However, as useful as this may be in comparing one location to the other, the impact that certain distinct stresses or unique stresses that are more relevant to one community to another community may be lost, or maybe the effects that are maybe disproportionately affecting one community versus another are not as exposed based on this weighting scheme approach. However, with this proposed approach specifically, the idea is to have dynamic weighting scheme where the weights would change as the data, again, continues to be fed and continues to be updated over time. And each of these weights for the selected stressor variables of interest will be tailored to that specific community. While this does not necessarily allow for one-to-one comparisons, this does allow to aggregate and to focus the efforts that need to be addressed for stressors driving the effects of health disparities within that specific community context. And an application use case I focused on in my work was more so using the personalized environment and gene study data as a cohort study run by the National Institute of Environmental Health Sciences, specifically on collecting chemical exposure data, social determinant data, physical health data as well, over the course of several years in North Carolina. And using data collected from participants from Orange County, Durham County, and Wake County, we applied this technique to then compare what stressor variables are actually selected using this technique, despite the proximity that these counties and participants in these counties have with one another. See if there are any differences in what was actually selected or what stressors were selected as being most important when we are trying to assess their effect on specific health outcomes. And while there are shared indicators across each of these counties of interest, we also determined that whether it was different environmental factors or social determinant factors or exposures, I should say, there were differing factors that were distinct or proved to be in to be significantly associated with specific health outcomes, despite the neighboring counties within this context. So we showed the application of this specifically in the environmental health context. Now, again, the focus more so on local communities in this work that I've done here. But that what is useful about this approach is that it's data agnostic. So it's not just relegated just for environmental health context, but also to other areas in health sciences as well, and the other data contexts as well. So we're going now from local to global in the work I'm doing now in my postdoc research. More specifically, related to global surgical care accessibility. So just as I mentioned with environmental health data specifically, close to 2 billion people do not have access to essential surgical care. And people who reside in lower middle income countries are overwhelmingly disproportionately affected by these disparities. And these health disparities associated with a lack of essential surgical care accessibility also pose significant economic impacts at a global scale. So it's not just affecting health outcomes of different residents within these different countries, but also the economies at a national and subnational level across the globe. So the idea is to then apply this framework and to see the feasibility in regards to global health work, specifically global surgical care accessibility, in ways we can identify factors that are contributing to lack of surgical care accessibility at a global scale, especially in lower middle income country status. So I want to mention that some of the indicators that help us to at least gauge global surgical care accessibility include accessibility to essential surgical care. So this is time to care. This is how long it takes you within a given time frame, say within 2 hours, to get access to essential surgical care, depending on where you live. Protection against impoverishing catastrophic expenditures for surgical care. So this is cost of care, and where this is going to how the cost of care impacts families or different people financially. And total surgical volume, number of surgeries actually performed within a certain geography, a certain area of interest, and as well as specialist workforce density, so the capacity to actually provide this care. All these indicators are measures for understanding accessibility to surgical care at a global scale. And there are many targets for the year 2030 that the Lancet Commission on Global Surgery set out and targeted for countries to reach by 2030. And there's still challenges in actually reaching these targets as well. Not to mention that vulnerable populations are also more predisposed to lacks or limits to surgical care accessibility as well at a global scale. So a lot of the work, initial work working on it was understanding different factors related to global surgical care accessibility. So this is, again, performing accessibility analyses using geospatial sciences, as well as leveraging data that's already out there at a national level, where we're talking about the World Bank data, World Health Organization data, and its relationship with different regions. Here, the main region here is Latin American Caribbean region, and different countries with different lower middle income status classification as well, and differences when it comes to healthcare infrastructure, as well as other health outcomes as well. And our understanding is that while these are clear metrics used to assess healthcare accessibility, healthcare outcomes, as well as other aspects, these are not the only factors to include, or rather to assess, when we're trying to understand accessibility in the context, not just for this region, but on a global scale. So let me see. How can we then develop an index or a tool, a screening tool that helps to characterize essential surgical needs? Well, just as mentioned when we were focused primarily on environmental health factors, again, this data integration concept comes into play. We're including not just clinical data, not just economic data, but social determinant data, in fact, environmental data too. So thinking in which accessibility to care, time to care, factors that may be limiting care. What are these indicators, and why are they actually important in regards to surgical care accessibility? What populations, what demographies are more disproportionately impacted by a lack of care, or what factors are contributing to such factors? As well as model development. What indicators from what we pulled, stress variable identification, are most important in driving this change, or driving or impacting accessibility to surgical care? And how can we then quantify this in a metric that helps us to what? Communicate this risk, or communicate these impacts as well. So that way we can transparently and clearly address the needs accordingly. So we're applying, again, some of these same data-centered approaches, these data agnostic approaches specifically in these contexts. And a lot of this work was supported of a series of funding schemes from my time at my doctoral program. So well, now in my fellowship here, where now I'm applying a lot of the same approaches, same work, specifically to address global healthcare surgical accessibility as well. And with that, that should do it. Let's see, yeah.
Sorry, I'm juggling a couple of different computers today.
Oh no worries. I realize I talk really fast, so I can definitely go over some concepts again.
No, let me sort of start where you ended.
Okay.
Having done some work with WHO on workforce, uh, what do they call it? Workforce assessment. It sounds like you have an approach that, if I'm characterizing this correctly, would offer a way not just to say, well, here is the number of nurses or physicians you need at this particular institution, but rather you would be able to effectively say, here are the forces that would influence the demand for healthcare services. Is that an appropriate characterization of your research?
Um, I would say it's close. It's close. The idea, at least we're talking about for a global surgical care accessibility, the idea is to similar to what I was talking about environmental health. We're trying to identify all these multidimensional and really multimodal indicators that may be driving or impacting accessibility to care. So some of these outcome response variables we're using are some of those target variables when it comes to time to care, surgical care density, healthcare expenditure. And the idea is that if we can show an association based on this framework of what are the drivers, then we can present this, let's say, at a national or international scale, like the World Health Organization, on what factors affecting maybe this community or this country specifically to actually address and then assess the effects towards accessibility to surgical care and improvements over time.
So it sounds like it would be much more nuanced approach in formation of policy and programs.
Yes. It's very tailored specifically to your location of interest. That's the ideal, not more so to compare performance between maybe country to country, but more so addressing the need and that specific context or a specific area of interest.
Okay. So we have something in the chat. Someone contributed great data collection and indexing presentation. What communication methods exist or are differentiated between the local context and the global context?
Yeah, so when at least for me, when it comes to understanding different communication mediums, I think that starts more so in understanding who you're actually talking to, the communities you're actually engaging with. And this is why I emphasize what I mentioned, right? I didn't really emphasize as much early on. One of kind of limitations in a lot of different tools primarily is dealing with that community engagement component, or at least engaging with stakeholders prior to development, during, and post development to ensure that those metrics are not just interpretable and understandable for researchers such as us, but also for those that are actually being impacted by those stressors. Hope that answers the question.
Well, there's a follow-up. Does
Okay.
your surgical research and needs include childbirth?
Yes, so it includes maternity days. So in fact, the surgical need index, one of the, not one of, the focus is actually on pediatric care, pediatric surgical care accessibility. So when it comes to global surgical care accessibility, it's already limited funding, limited work in that area. And then we talk about more focusing on those vulnerable populations, such as children, then that would also include childbirth data and maternity data as well.
Okay. Let's talk a little bit about the community approach. That's really quite fascinating. Um, I guess the question that comes to my mind is the feasibility for community groups to access this kind of expertise to evaluate their environmental health challenges. You gave a couple of examples of, Flint, Michigan, the Cape Fear River PFAS issues. Are there particular triggers that a community group could look for to help prompt them to start asking questions? And if they had those questions, how would your tools be available to help them?
Yes. So I'll try to answer this. One part, accessibility to the tool. So the idea of the frame is more so, and I kind of use those terms interchangeably in the presentation, but the idea is to have it to be a framework, kind of a guidelines for whether it's local health departments or even local community members, nonprofit organizations, local community organizations can then apply it and then assessing what's actually needed for that context. So that way, in areas where there is resource deprived or may not have just the human capital to actually access subject domain expertise, they can then apply it for their needs in that regard. Now, when it comes to identifying maybe triggers in that regard, as you mentioned, it would vary on, I guess, the context of what the issue is. So if they're noticing, and sometimes it depends on, it could be a local physician there and noticing they're getting a lot of patients with elevated blood lead levels, for example. And then that can be a trigger in that regard to actually then, okay, let's see what could be causing this. So what could be the source of exposure in this regard? So I think it varies on what that trigger would be. But yeah, I don't know if that answers your question. I kind of went on a tangent.
No, it's okay. I did work in biosurveillance for a few years, and one of the biggest challenges was trying to take these large-scale events and try to translate them so that people at the local level could understand what to look for and be able to respond appropriately. So let me ask a little bit more, and feel free to tell me no, you haven't studied that. But this kind of approach looks like it would have a framework that would be helpful, certainly for those monitoring groups in government and in even NGOs that are involved in these kinds of events. And I'm thinking specifically about Flint, Michigan, where, and to a degree, the Cape Fear issue. This was a long-standing issue, but it did take some clinicians and others who had some technical clinical knowledge and experience to be able to say there's a problem here that even the official organizations have not dealt with. Would it be feasible? Now we're moving into the solution area. Would it be feasible for the types of tools and frameworks that you are developing to be able to look at data community by community and be able to produce a sort of set of localized indicators to help people understand you might be looking for this issue, or not necessarily explaining what it is because you don't know what it is, but the evidence might help them see an issue where they would be able to use their own local expertise and their own technical expertise to be able to highlight the issue and bring it forward for attention by official and other agencies.
That's the objective, honestly. You hit it on the head. That's the objective. The idea is more so to, again, to help provide transparency, not just, again, as from the researcher side or those what's the word I'm looking for? Researchers or like risk assessor side, but also for the community members to be able to have agency when it comes to identifying what's actually contributing to their community, most relevant to them in that regard. So that's actually in fact, one of the main objectives of developing this framework specifically for that context. So yes.
So, and it's interesting that there's always a local context and even a local agency, no matter where you're looking in the world. It may be understaffed and facing all those kinds of challenges. But how would you advise local advocates or health departments to use the type of tool you're developing to support stronger protections and to avoid overinterpreting or misusing the indicators that you've developed when they're particularly not just trying to understand the situation they're facing, but also how they're talking with the public about it?
Um, so for one, I would say focus on what's actually relevant. Focus on what's actually relevant in your context. I mentioned in comparing a lot of the kind of the big name environmental screening tools, specifically. Again, their focus is more so comparing location to location for a set number of indicators or set stresses that they're focused on, or what's actually being monitored at that given geographic level. But for those local communities, I would say focus on what you actually and what you're seeing, and then tailoring it to what's actually relevant to you. That's what I would say. The idea is to have this to be more so another word instead of tailor, maybe more bespoke method or bespoke applied, if that's a way of phrasing it, for that specific community of need.
So, is there a way? I mean, it sounds like you're approaching the framework that would be able to operate at a global level, a national level, a localized level, perhaps even simultaneously. Is that a fair way to put the possibilities?
Yes, it is. Yes, it is. Yeah, it would. I have nothing else to add for that. I mean, I can go on, but it is. Yeah.
But what I'm thinking is this would be something that would be of interest to people in global health, particularly the World Health Organization, because they do and have sponsored these kinds of tools to help people devise national policies as well as support local efforts. And so I'm thinking there's a pathway there, and your research is going to get some notice, but some of it is also being able to explain this to officials in context, ideally, but sometimes just being able to attend the meetings and do that. I mean, what are your next steps in thinking about the continued development of this approach?
Yeah, in fact, right now we're partnered with nonprofit organization, specifically, especially when it comes to pediatric surgical care, the accessibility, in developing this tool to help their efforts in providing accessibility care and medical supplies, specifically in the Latin American Caribbean region. So we're already in talks with that and developing a partnership with that to apply and then test the framework in that context. These versions of the framework in that context, yes.
Okay, that sounds very encouraging. And it also suggests that maybe this is, and I'm going to touch on politics, but I'm not going to get very involved in it. There are some major changes taking place in national environmental health policy in the United States, but one of the ways that I have heard people talk about these changes is that, well, maybe the local and state communities could step forward to be able to perhaps think about the framework and tools that you're developing to help guide their steps in this area where maybe the national policies and resources are not as robust as they once were, but the states and the local communities actually would have a role and could use this to continue your work and make it more practically applied.
No, I 100% agree with that. It's the fact some of those main tools I mentioned are no longer at least publicly available for use, given recent issues. So yes, definitely this would be, again, not just with a local concept, but at least the idea is to provide as a framework that can be used and distributed for use as needed, especially in cases, as you mentioned, where there could be, I'll put it, maybe political upheaval when it comes to issues related, especially with environmental policy. So yeah, in fact, some of the same tools I mentioned, aren't actually publicly available any longer.
Okay, I'm hoping somebody on the Zoom call is going to step forward with another question, or submit it into the chat. Yeah, come on up. All right. We have a question in the room here, but the microphone is in the front.
Okay, can you hear me?
Go ahead.
Oh, can you hear me?
Oh yeah, I can hear you.
Okay, awesome. Yeah, my question is a little more general. How did you get interested in this as a topic to pursue?
That's a good question. So I probably should have talked more about, I guess, my background. So I attended North Carolina Central University, and that's when I first got interested in health disparities related work. I was a pre-med major, so naturally, I guess a pre-med major, you assume you're going to go to medical school. Clearly, I didn't go to medical school, but I did have that interest in health disparities, and that was cultivated initially there. And I got interested in actually merging more data science, bioinformatics, biostatistics in relation to addressing health disparities issues while I was at North Carolina Central University. How I got into environmental health was the lab I joined when I was in grad school at NC State University, and realizing that health disparity is not necessarily always in the clinical sense, but also the effects on the environment and effects of health. That environmental epidemiology, exosomes, exposure science. That's where I got my interest in that. But I always wanted to address work and health disparities, and I just found a way that I could do that using more technical and data-based approaches.
So what do you see both in your personal profession, but also in the impact of your work? Where do you see this leading?
Good question. Kind of back to, as I mentioned, my interest in health disparities. I've always wanted my work, or at least, I guess I don't like saying my work. I feel like it's a collaborative effort anyway. But what I want to do, I want to be able to contribute towards addressing health disparities, especially via data-centric means. And I want to be able to actually have an impact in that regard, especially when it comes to communities that may be resource deprived or just have a lack of resources or even attention. So be able to pick up and identify areas of need, especially not have put feet on ground in that regard. I would like to do that. That makes sense. Whether it's at a global level, even a local level, if I can at least impact health disparities in some way, I would like to do that.
Okay.
I was just wondering if you could post in the chat your email address?
Yeah, sure. Okay.
Thank you. Well done.
Thank you.
Sorry, Deborah, I didn't see your hand. Okay.
Thanks, David. Good job. I'll lower my hand.
All right. I think we'll wrap it there, but thank you. This was an excellent and very interesting presentation, cutting across so many areas and so many levels. Brilliantly done. Thank you.
Oh, thank you. I appreciate it. I'm glad there's interest. So I appreciate the invitation.
You bet. All right. Well, folks, we'll see you all next week.